David, we're participating in some studies in the future with this drug. I have not had direct experience with it yet personally. I will soon. I don't know if what your take is on this data, as well as any of your anecdotal experience you have with the drug.
Right, I agree with all your comments. It is a well-tolerated drug. It's interesting that for chemotherapy, phase 1 trials always use a design where we go for the MTD, the maximum tolerated dose, based on dose-limiting toxicities. And it's figured the more you can give, the better. For targeted therapies, different companies have used different approaches. Some still use the MTD, and others say, I want to get a biologically effective dose, and they may do that based on surrogate markers, biopsies, blood tests, etc. So here's a drug where they escalated log fashion, many-fold, and they never got to the MTD. So they said, well, it was pretty well tolerated, so we're just going to give the highest dose. I don't disagree with that. But as you said, even much lower doses of the drugs were effective in some patients. So I think there's a lot about this drug we don't know. What I have not seen, and because there have been multiple presentations, I have not yet seen the co-mutation status with this drug in this study. In other words, what about patients with P53 plus this mutation or STK11? What impact did that have? The other thing about the drug, and there was a separate abstract at ASCO, was using the very same drug in the patients with the very same mutation.
Yes.
But colorectal cancer.
Yes, I was going to ask you.
And it was 1 out of 25 patients had a response. That makes me think that co-mutation status is important.
Yeah.
Because it's not that the colorectal patients had a different KRAS mutation. They had the same mutation. But undoubtedly, just based on prevalence data, we know that P53, STK11 are not the same prevalence in colorectal. So I'm thinking maybe the traveling partners do make a difference, but it's too premature to say that. We'll come back to this when we talk about some of the competitors where maybe there's more efficacy data on colorectal cancer.
Yeah, it ran counter to me. I was expecting, we're talking about these tissue agnostic genotype directed studies, NTRK fusions, RET fusions, and which we're seeing similar response rates no matter what the tissue of origin is. And this was a little different. The data, I agree, the data is just too early to know, but gosh, it seems like there's such a difference if you have a KRAS G12C lung cancer and get treated with this drug versus a KRAS G12C colorectal cancer and get treated with this drug. And well, I've never heard of the co-alteration hypothesis, but it's one I think that could have a lot of traction here.
And I just want to mention that earlier I said KRAS mutation in colorectal cancer versus KRAS mutation in lung cancer are very different in terms of prediction of response to EGFR monoclonal antibodies like cetuximab.
Yeah.
So again, this isn't the first time we've heard this story about KRAS being a different beast in the two different malignancies. Well, where does this drug, this Amgen 510, where does it stand in terms of the approval process?
I think it's got correct me if I'm wrong, but a breakthrough designation or fast track designation. I think the difference between that lingo is whether it's an unmet need or if there are existing therapies that exist already. But I think this will move quickly. We are participating in some of the combination trials, but I hope with a fast track designation that this will reach the clinic sooner rather than later. I don't know we're in April 2020. I hope by the end of the year, if not early first quarter 21, we've got this drug in our armamentarium to give patients. I don't know what your thoughts are. I'm ambitious, I think, on my thoughts on how long it will take. What do you think?
I agree with you.